that's where we left off the other day, right? We were showing how the pictures of how the blood cells are produced. And I think that's really cool that when you see the reticulocytes, that's the last step before the mature red blood cell. And I think that's a really cool way when you're looking at your blood work and looking at your labs and interpreting them, and you see if you see greater than 3% reticulocytes, what's that going to mean? Destruction, right, yeah. You're making it, your body's making them, but it's churning it out as quickly as possible. But it's being destroyed as it's going on. So, and then if you have the less than 3%, what is it?
Production.
Yeah.
Underproduction.
So you're not able to produce it, the underproduction. So one of my pet peeves, and if you're in my clinical group, you already know this, but if you have a hemoglobin, if your patient has a hemoglobin of 8.6, and you say because of anemia, that is anemia. Why? So what's going on? What do you think is going on with that patient? And your CBC, like your white blood cells and your platelets, that's not anemia. White blood cells and platelets do totally different things than the red blood cells do. The lifespan is different, and the production time is different, and what triggers it is different. So when you're interpreting your CBC, WBCs do that separately, and platelets do that interpret that separately. And then the red blood cells, hemoglobin, and hematocrit usually have about the same reason for being abnormal. Maybe not always, but usually. So this is just a neat little picture. We can have deficient nutrients like iron and vitamin B12 and folic acid. We're going to talk about those types of anemias, the nutritional anemias. And it doesn't necessarily mean because you're not eating enough, but the nutrients just aren't there. But if you're not eating enough, too, that could be an issue as well. And then to decrease erythropoietin, because we've had lots of patients that have been in some degree of renal failure. Have y'all, or at least this chronic renal disease anyway? How many people have had a patient with renal disease? Because there's really a lot, aren't they, there? And they may be coming in the hospital for something else. And so what are their red blood cells and hematocrit and hemoglobin going to look like if they're not functioning, their kidneys aren't functioning well? You're not going to be making so many red blood cells, are you? And then we've got decreased iron availability. You've got to have the ingredients, don't you? You can't make hemoglobin if you don't have enough iron stores. So if you've got problems with your liver, that can be an issue. And then we've got the blood loss. You can have blood loss that we don't see. It would be if it was an ulcer high up in the GI tract. What would the stool look like if it was way up high bleeding?
Dark black.
Yeah, it would be black. Right. And then if it's bright red, then you know that it's lower in the GI tract, the bleeding. And has anybody taken care of a patient with GI bleed and seen what comes out of the NG tube? Have you seen that? Mm-hmm. What does it look like?
Coffee grounds.
Coffee grounds, exactly. Yes. And then here you got the acute trauma, and that's when you got the holes in the blood vessels, like she was showing in the drawing. And then the increased RBC destruction, and that can be with like hemolysis. We said that the other day that when you're hemolyzing a cell, that means it's bursting. It's not intact anymore. And then sickle cell disease can cause that. Medications like Aldomet, methyldopa, blood pressure medicine, incompatible blood can cause it to blow up. That's an immune reaction. And then trauma, like a cardiopulmonary bypass, sometimes the trauma can make them burst as well. Let's see. looking at my notes, I think I've already said about all of it. So anemia, in your IGGI book, it says that anemia is a clinical indicator. It's not a specific disease. It is kind of a condition, and some people do have it chronically. So we can say that people have chronic anemia, but it is not really a disease. It's an indicator that there's something wrong with the process of developing the red blood cells, or producing the red blood cells, or they're being destroyed, or you've got bleeding. So I think she's already told about all those other kinds of things. Okay, and I do have some tables listed in the notes page. The table 42-1 has common causes of anemia, and chart 42-1 that except that was in the older version. Sorry, the 8th edition, I have it listed as well. The manifestations of anemia, and so those are really important. And I also, this was from when we first started the concept-based curriculum, that Pearson had a specific book that followed all of the different concepts that are in the North Carolina concept curriculum that they kind of came up with. This is what every aiding program in the state is doing. If we adopted it and the State Board of Nursing, I mean, it's required now for aiding programs to do that, and some other programs do it as well. But anyway, I did just post. I know I've posted a whole lot of stuff. I just have a lot of stuff because I'm a cancer nurse, and hematology is in there too. It doesn't mean you have to read all of that stuff or all of those websites or all of that stuff. Just look at the directions, though. I did have a few things in some websites that I wanted you to look at that are in red, but the rest of it is really just something that you can come back to if you've got a patient with anemia or with cancers, to be able to take care of your patient better and maybe relate it to what we learned in class and lecture and all. But anyway, that concept book did have some really good charts and tables that I pulled out when we changed books. We did change books because some of it was kind of hurriedly done. Some of them were very thorough chapters, and then some of them were sketchy. And so we decided that we would go into a regular med search book, and not one that just gave the exemplars that are in our curriculum, but gave some other conditions too, so that you could look those up when you're doing your pathos in clinical. So, okay. Now, this is gross. I should have warned you. I'm sorry. But this really is a shark bite. So you're losing your circulatory volume, and your cardiac output decreases. Your viscosity, what does that mean?
Thickness.
How thick it is. Yeah, so the fluid is shifting to the vascular space from the tissues to be able, because the tissues are signaled that they need to let go of some of their liquid to try to fill up the vascular space. And then the peripheral vasoconstriction happens, so that you're squeezing them shut, and then the compensation starts happening too, because we're not perfusing, we don't have enough blood. The heart rate increases and the respiratory rate increases to compensate. I heard people talking in the bathroom about this, but that was dear Noir somewhat, wasn't it? About how do you know somebody's bleeding? Was that a question? Something about the symptoms? If they're bleeding, you're going to have increased heart rate, respiratory rate, and low blood pressure, and all that kind of stuff. So y'all really already know that, don't you? Probably didn't even need to say that, but shock and circulatory failure can happen if we lose too much volume. So in acute blood loss, if you do have enough iron stores, especially in your liver, there's some in the spleen and such too, but you can really kind of replace that within about 3 to 4 weeks. And the red blood cells that are circulating will be normal size and shape, and so the word for that is normocytic. So CYTIC means what? So when you're referring
normal
to
size and shape. Normal size and shape. Red
right, of the
red blood cells.
The cell, right. So a CYTE is cell. So yes. So normal size and shape of the cell. But if you have chronic blood loss, like you just gradually, if you have an ulcer that's bleeding, you don't really even know it. Maybe you do know it, but if it's gradually having a leakage out of the body, then you're losing your iron stores, and so the new red blood cells don't have enough to make hemoglobin, and that's mainly what's inside the red blood cell, isn't it? It's just hemoglobin. And we don't have the nucleus or any of that. We just want to carry oxygen. So, but they become small. I mean, the new cells become small because there's not enough resources to make normal cells, the normocytic. So we call them microcytic. That makes sense. Small cells. And then hypochromic. When you're talking about chrome, what's that song? Paul Simon, Kodachrome or something like that. So, but chrome means color. And so if you're saying hypochromic, then that makes the cells are pale. If they're hypochromic, that makes them pale. And so that's because of the lack of the iron. So, okay. Ooh, that's not a good picture, is it? Where I got that weird little color there. But anyway, she's already talked about the erythropoiesis, that's red blood cell. Erythro means red, and poiesis means like the making of it. So you're making red blood cells. So you have to have nutrients, and we know iron, don't we? That's part of hemoglobin, isn't it? And we need other minerals as well. And then we have to have proteins that contain amino acids, B vitamins, B12, folate for RBC synthesis, and then vitamins C and E are critical as well. And if you don't have the nutrients, it may be because of an inadequate diet. And that's one of the things that frustrated me on y'all's nutritional assessments back at the end of our fall semester is that when somebody was anemic, what could you do, even if it's because of renal failure or bleeding or something like that, if you could help supplement it, and at least it may just be a drop in the bucket, but maybe a drop in the bucket will be helpful. So you can look at your nutrients. If your patient is anemic, you can say something in your teaching plan about how to get iron-rich foods. And then you may have a malabsorption of the nutrients. There are some people that can't absorb some of the B vitamins, and sometimes iron's not absorbed well either. And then sometimes it's an increased need for the nutrient. So, I spoke before I even looked at my notes here, but yeah, the My Plate for the more details if somebody's anemic and the blood building foods for anemic patients. So. What would be some good that you already know about that would give iron?
Red meat.
Yeah, red meat, and what about this organ meat here? Liver. I think I might rather do tail. Maybe if I had to, I would. Not me. Anyway, I guess if you have to, you just do what you got to do. So, okay. All right. Here's one of our anemias, iron deficiency anemia. It's the most common type in children and adults. And this is actually a slide that I did a long time ago. I fiddle around with them and everything, but it actually came from the maternal child book. It was like the second edition. But anyway, I doctored it up too because it was added results and that sort of thing. But it can occur because of the blood loss, of course, and 9 to 11% of the adolescent females have anemia, primarily due to menorrhagia, or I don't know how to say that. But anyway, what is that? It's real heavy period, and so you can become anemic. That's a pretty big number, isn't it? And sometimes there are young girls that end up having to go on birth control pills to regulate their period, because it's so that it will not be so heavy, because that's really an awful thing to be anemic and trying to play sports and trying to do all that you have to do in school and got a job and all that. That's kind of tough stuff. And then we got increased demand for blood production. When would you need more demand for production? Think about what Miss Chandler just said. Pregnancy is one of them for sure. So, and then if you have poor nutrition, of course, that just makes sense. And then if you don't absorb the iron, it's not going to give you good either. So, the chronic bleeding is the usual cause of the iron deficiency anemia in adults. And it can be from, of course, you said ulcers, but you can also have GI inflammation and other places. And if you have really, really bad hemorrhoids that bleed an awful lot, that's one thing. And sometimes we really did see a whole lot of cancer, colon cancer patients in our office. That's one of the top 3 in incidence of cancer. But sometimes, what do you think? Maybe that you might be able to look at a lab and if you're trying to figure out why that patient's all of a sudden anemic and they haven't been for the last several years and now they're anemic, what would you be maybe suspecting then? That you could, sometimes that's the first sign that somebody's got a colon cancer, got a tumor, because it's making it bleed. So, okay, and then people that are, of course, the menstrual blood loss, we said that, and adult females can certainly have it also, and sometimes they end up, if they've already had their children, they end up having a hysterectomy because they've lost so much blood, and you probably know people that have been in that situation. So, breastfeeding is a big demand too. You really need to have plenty of iron with the breastfeeding. My kids were born. Let's see, my youngest was. Let's see, he's going to be 24 in March, and but my first 2 for sure. They made us give, if you're breastfeeding your child, they made us give iron supplements, this liquid iron supplement, or vitamin product with iron, and it was just all, it looked like iron. It just looked like rust kind of stuff. And I remember Tom, he knew that when he saw that thing coming, and he just as a little bitty baby, he would just tighten up and everything, and you could hear when it went down and he swallowed it, you could hear it bounce, and it would just come right back up. Maybe not all of it, but it just would when it closed. He had breast stains on his clothes all the time, so he had that iron so bad. I don't think they do that anymore with breastfeeding, do they? They don't make you take the iron anymore. I think that's what students had told me before that have had children much more recently than I have. But anyway, children and pregnant women that are deficient in iron can experience a strange kind of thing called pica. Have you heard about that? What does that mean? Oh, y'all work with the obese stuff, don't you? Yeah. So do they want to eat like clay or dirt? Yeah, just all kinds of strange stuff, and they have a craving for it, and that's what they want. That they eat glue or whatever. It just gives them strange cravings for non-food items, and that can make especially children susceptible to lead poisoning, because if they have if we're in a real old housing development or something that's got the lead in the paint and it's peeling, and then they've got that pica, they just want to eat the paint, and then that can be a real problem. So poor children are more susceptible to the lead poisoning, of course, and it can lead to learning failure. That's a real developmental issue, and that was one of the big deals for that Flint, Michigan issue, and all the water had so much lead in it. And lead absorption increases when you're anemic. If you're already anemic, if the child is already anemic, then they absorb the lead really, really well. So that's really dangerous. So Hispanic and African American and Native American children are at increased risk for inadequate iron intake. And just this, and you don't really have to memorize this, but just for FYI, the 2/3 of adult iron is in the hemoglobin, so most of the iron in your body is in hemoglobin. 1/3 in the bone marrow, and the spleen, and the liver, and the muscles, and that's where your iron stores are. The bone marrow has to have some, of course, to make the blood cells, but the other biggest storage area is in the liver, and then the spleen and muscles. And then the iron stores are depleted first, and then the hemoglobin would be depleted, and so you're not going to have ability to make the cells. All right. So this is iron deficiency anemia. The red blood cells. Yeah, I usually can't alter this, but yeah, here hypochromic. That means they're pale. They don't have enough color. You can see they don't have enough of the hemoglobin. And it's a result of increased hemoglobin synthesis, and they're smaller than normal. You see all different sizes of them, but a lot of these cells are smaller than normal, so the micro-cells. So that's just a FYI picture, sort of. And so what are signs and symptoms of anemia? We've already said some, haven't we?
Tired, short of breath.
Yeah. Tired, short of breath. And we look pale too, don't we? And if you have darker skin, how will you tell if somebody's pale? Yeah, look at the gums and look at the conjunctiva. Pull down the eyelid, kind of the bottom eyelid, and look and see if that's pale. And what happens like with the nail beds? So you might not have the cap refill that you normally would have had, right? And then your skin can be real cool and clammy. It makes you cold, doesn't it? If you're anemic, the people that are anemic are cold, aren't they? They feel cold, and they sense that they feel cold. It's not just like you touching your hand and it's cold. Yeah, that too. But so we already said the heart rate and the respiratory rate are compensating, and that helps to increase the cardiac output and to attempt a better tissue perfusion. And then if you're not perfusing to the myocardium, what are you going to have? Yeah, what do you call that? Yeah, angina. That's right. And so we did have a patient that had medication for that as a PRN this week, didn't we? And then the dyspnea on exertion with that fatigue, if it gets really bad, like Jennifer said, it can really be like activity intolerance. You can't do a whole lot. And then you can have cramps in the night. Why would you have cramps? Because you're not doing what? Yeah, you're not perfusing, are you? The tissues are not getting the perfusion they need. And we always kind of think that it's potassium that they should have cramps. Well, yeah, if you have potassium issues, that can be too, but you can have the cramps from lack of oxygen. So this is a huge thing. And I've probably said it before, but we're going to say it again. Tissue hypoxia is what stimulates the erythropoietin, not decreased red blood cells. But of course, with decreased red blood cells lead to the tissue hypoxia, but the stimulus for the erythropoietin production and release is the tissue hypoxia. And so that's really kind of what goes on with the COPDers, isn't it? Once they don't have the CO2, they don't respond to the CO2 anymore because they've got so much in them already that it's a hypoxia issue with the COPDers too. So tissue hypoxia stimulates breathing in a COPD patient and the erythropoietin release, and then it tells the bone marrow, and y'all saw all that in the film there. And you can, if you do have a bleed or something like that, where you're trying to hurry up and churn as many red blood cells. You remember how long it took from the erythropoietin released to the production of the mature red red blood cell, 3 to 5 days. And so if they're churning and making just as many as possible, the release of the red blood cells may not happen as quickly as they're being made, and so you can really have a bone pain issue because they're producing so many, and it's packing the bone marrow, and it can cause bone pain. And sometimes you can even have bone pain so bad with erythropoiesis or like white blood cells that are developing really, really fast in response to a problem that it can even require opioids. Sometimes it can be that bad. Usually it's just an ache, but it can be extremely uncomfortable. So the cerebral hypoxia, we were talking about breathing before your test, taking a deep breath, and you need to have oxygen, don't you? So we're going to just look for like headache, dizziness, and your vision can't be as good if you're not having the oxygen to your brain. And then heart failure can develop in severe anemia because the heart's working so hard and it's not getting oxygen itself, and so it can fail if you're not using myocardium. Okay, so we got our pallor, our fatigue. We can be irritable. We don't feel good. Nail bed deformities, and this is an issue for long term. You can have clubbing if you've got long term anemia. And of course, we see that in COPD years as well. Growth retardation in children, especially if they've had the lead exposure. Developmental delay can happen with that. And we've got our increased heart rate, and our systolic heart murmur can be the cause of decreased blood viscosity. If somebody is not born with a murmur and then they develop a murmur, and you see that they're pretty much chronically anemic, then you can kind of think, okay, that's the reason the blood is not as viscous, it's not as thick, and so it swishes more when it's a thinner blood that's going through the veins and the arteries. So, and we're going to have to stay for a while because we've got I'm sorry, if y'all have to go, you can certainly go, but we're going to have to cover this stuff, and we're not going to get it done if we don't keep going here. Because I was supposed to have 11 to 12. So, anyway, so it is the most common anemia worldwide. Women and older adults, and people with poor diets, and especially with children and such too. And a lot can be lost in the feces, and we do because what colors our feces? Brown. It's violet, and so it takes some iron to have that brownish color. And so at our diagnosis, we've got our CBC, decreased red blood cells, small red blood cells, and then the malformed RBCs, of poikilocytosis. That was in one of the pictures from last week. So chronic iron deficiency. Okay, this is something you need to remember, that it is hard to separate sometimes B12 deficiency and iron deficiency symptoms, but brittle spoon-shaped nails, and chelosis is cracks at the corner of your mouth. Have you ever had that, like when you drool or whatever at night? You ever drool at night and then it gets irritated because you've got enzymes in your teeth? So, but it can do that as an iron deficient issue as well. And so you can have a real smooth tongue also. We've got bumpy tongues. Our tongues are supposed to be bumpy. So the sore tongue, and then that pica where you want stuff that you're not really supposed to be eating. So our best source of iron is lean red meat, and it also can be found in chicken and turkey and eggs and cereals, especially cereals and breads that are what? Fortified. Yeah, fortified. So, all right, and do remember this. This is very, very important on the notes page, the iron absorption. Well, I have it in there in red, don't I? Remember this exclamation point. Okay, so it's enhanced by vitamin C, and it's inhibited by tea and coffee. So think think about that. We do it will inhibit iron absorption if you drink a lot of tea and coffee. And maybe if you have just a little bit, that's okay. But you don't want to just drink that all the time because it's gonna mess up with your iron. If you're just extremely low, you may have to watch out and not drink that anymore for a while. But that they told us we had a nutrition class in our first year of nursing school. I had a 4-year program, and we actually did have some nursing classes in our freshman year. They changed that like 2 years after I started, but you did all your pre-reps. What's that? Oh, yeah, I guess I'll do that. Okay. All right. So, okay. Anyway, the tea and the coffee are not good for you, and the like orange juice is what our nutrition teacher told us that was a good way to be able to take if you're taking an iron supplement or you're eating something that's full of iron. If you're eating liver and all this sort of thing, they didn't really say liver here, but liver certainly does provide iron as well. But the deficiency can be, of course, like we said already, blood loss, poor GI absorption, and then the inadequate diet. And organ meats are especially high. Egg yolks have more iron, of course, than the other part. The other part is just like albumin, but it is still protein. The white of the egg is still protein. And kidney beans, the red kidney beans, that's why they're red. They contain iron. Green leafy vegetables, raisins, and blackstrap molasses. And I don't know if that's still, I did not check if that link still works, but it was in Wikipedia talking about how blackstrap molasses is something that's sort of left over from the production of the molasses, but it's just real rich. And it really does have it's different than just eating regular molasses. And you can cook in an iron skillet. And that's what they told me when I got anemic, because I was given blood every 2 months, and when I just first got out of college, I was 21, and I gave blood every 2 months, and one time they saw that my hemoglobin was too low. They used to put a drop of your blood from your ear or your finger in copper sulfate. It was a blue solution. Julie, did you ever deal with that? Because they can just do it with a machine now. But if it didn't drop down, if it floated, then it was not heavy enough. They didn't want enough hemoglobin in there. You didn't know exactly what your hemoglobin was, but it was too low anyway, because it was a certain percentage of copper sulfate in there. Okay, so you're going to cook in an iron skillet, and I put Mr. Wizard on there because it was the coolest thing with fortified. We talk about fortified foods. I took my kids to the Horizons place. They had a Mr. Wizard presentation at Horizons when my kids were real little, and he took cereal. I don't remember which kind of cereal, but he cut it up in a blender. He threw it in a blender, and then he took a big magnet, or one of those horseshoe magnets, stuck it down in the blender after he took the blade out and everything, and he had all these little iron filing things stuck on the magnet, on that horseshoe magnet. And that was the coolest thing. You pass that around, and you could see the little iron filings in there. And when you do cook in an iron skillet, if you do a grilled cheese sandwich or make gravy in it, or do your eggs in it, or whatever, you're going to get some iron from that. So that's a real good thing. If you're not using an iron skillet and you are anemic, that's a way to get iron. So maybe you won't have to eat liver. So, but anyway, only 5 to 10% of the iron that we have in our diet is absorbed, and that's part of, it goes through us. And you've got brown stool, that's part of that is iron. iron sulfate supplements, FeSO4. I think some of our students have already given that, iron sulfate. And you can take it between meals for the best absorption and less GI distress. But sometimes you gotta do it according to how your body responds. Sometimes you need to have something on your stomach. So if it's a real severe anemia, iron supplements can be taken in IM or IV fashion. Did you talk with Ms. Walker in medication administration with IMs with the C-track that when you're given iron, and that's usually Imperon, or I don't know, that may be really just a brand name, but that's something that really is irritating to the subcutaneous tissue. You want to make sure it goes away deep into that muscle and it doesn't go back up the plaque. And then with the IV route, you can have infusion reaction sometimes. So it's a risky thing. So taking it in oral supplements is really better. Okay, so switch gears here. Vitamin B12 deficiency necessary for DNA synthesis. So that's pretty important, isn't it? That's what we're made of, how we're made, derived from animals. So B12. So failure to absorb the B12 is anemia, and that means you don't have intrinsic factor. I'll explain that in a little bit. It also could be decreased B12 intake, which is rare but it's not rare in vegetarians or vegans in particular. So they may have to take supplements. And the Schilling test is something that they keep saying that students don't know what that means or what that is, and it's on the NCLEX or on the Kaplan test and things like that. So you do really need to know what the Schilling test is. It's a 24-hour urine collection, and it tells if there's a deficiency due to the lack of intrinsic factor versus other malabsorption disorder. So you can look in your lab book about this, but we really are dependent on this B12 because it matures the nucleus of the cell. That's how it makes a mature cell. And then the dietary deficiencies are rare, except in strict vegetarians, like we said. Okay, so here I've got it all underlined in on the notes page. Intrinsic factor is secreted by the gastric mucosa, and it helps to absorb the B12 in the ileum. So it's made in the stomach, but it goes into when it gets down to the ileum. We got our duodenum and the jejunum and then the ileum. So it's not absorbed until it gets into the ileum, but it has to combine with the intrinsic factor to be able to be absorbed. So anyway, the malabsorption conditions can be, now this is something to really think about. If you have stomach surgery, a resection of part of the stomach, that probably means that you're not going to be making enough intrinsic factor to be able to absorb your vitamin B12. So that can be this like surgical removal of stomach tissue. And or the ileum as well, because if the ileum's not intact, you're not going to be able to absorb it through the ileum either, even if you've got the intrinsic factor that came from the stomach. You got gastritis, that can mean that it's not going to produce the intrinsic factor. And if you don't have the right pancreatic secretions, or if you've got diverticulitis, you've got that sort of irritation, chronic diarrhea, tapeworms, overgrowth of intestinal bacteria. There's just all kinds of things that can decrease that absorption. So the symptoms can develop gradually, like the smooth sore, beefy red tongue, and that's like what else would we just say? Iron deficiency, right? So that's what I can't ask you a question and say which one is and sore and all that sort of thing. But you can have diarrhea with this. The B12 is important for nerve function. That's the biggie to distinguish. We know that the iron is helping us make the red blood cells mainly, and it leads to being able to have tissue perfusion. But nerve function is a big deal for this. So that's how you're going to differentiate the B12. If you've got like paresthesias where you've got pins and needles or numbness in your fingers or toes, and proprioception, I guess y'all probably have that neuro, but the sense of the position in space, like where are you? Are you gonna fall over or whatever? It can make you lose your balance. And so if you detect the B12 deficiency and then you know that it's going on and you can do supplements, it's reversible usually within 6 months. But if you don't detect it, then the treatment can be delayed and it can make the symptoms permanent. We had a lady one time that she was having like memory problems and stuff, and we found out that she was B12 deficient, and she did a lot better once she got started on her B12 supplements. She had injections. Okay, here's our B12 picture. So we got our eggs and our milk and our meat products, really, it's animal products. So deficiency prevents the activation of the enzyme that moves folic acid into the cell, and that if you don't have the activation of that enzyme, then you're not going to have that make the DNA. Actually, folic acid and B12 work together with the DNA part. But these abnormal red blood cells, and they get enlarged. They're macrocytic cells. They start looking oval and not concave anymore. They're thin and they're fragile, and their lifespan's shortened, and they're not 120 days anymore. It can be much shorter than that. And so that may decrease the carrying of the oxygen to the tissues as well. And vitamin supplements can be prescribed for B12 anemia that's really severe. If the pernicious anemia is present, when you don't have that intrinsic factor that's made in the stomach, then you're going to have injectable B12. It's like once a week, and then maintenance monthly for a lifetime. Maybe if you don't have, if you can't ever make the intrinsic factor, if you can get the cause cleared up, like diverticulitis or something like that, then you may not have to do that forever. But there is a new nasal spray called Calamist that you could use instead of shots as well. And B12 also is in nuts and leafy green vegetables and citrus fruits and dried beans. And so we have iron in that kind of stuff too, don't we? Oh, not so much with the citrus fruits, I guess, but the dried beans and the leafy green veggies and the nuts are good. So, all right, so we'll go to folic acid. This is something that's required for the DNA synthesis too. So both of them are. You don't really have to know the part of the two. Did you have a question? Tell that. Okay. Is that okay? I'm sorry about that. We started kind of late. Okay. So it helps to mature the red blood cells so that they can most efficiently do the tissue perfusion, and that. So all of these factors, these nutritional factors, the iron and the B12 and the folic acid, really are they all somewhat work together. If you're chronically undernourished, like in older adults and alcoholics and drug addicts, I find it every time I see it at the hospital, one of the students' patients has all these B vitamin supplements. You kind of, I guess it's a judgment or something, being judgmental, but they may be an alcoholic though, because that is a lot of times alcoholics have to have that because their stomach's so irritated it can't use the intrinsic factor or they can't absorb any of the B vitamins. So you can have also the pregnant women are at risk because they need more folic acid than a non-pregnant woman would. And malabsorption like Crohn's disease and celiac sprue, which is the gluten allergy. And then medications like methotrexate. Has anybody heard of methotrexate that you could take like for rheumatoid arthritis. It's actually a chemo drug that you can use for cancer too, but it's called an anti-metabolite, and it messes with the folic acid absorption and all too. And anticonvulsants and oral contraceptives can slow down the folic acid absorption too. So we're going to have, if we have this kind of anemia, even if we got iron and we got B12, but we don't have the folic acid, we still get pale and weak and fatigued and short of breath and palpitations and irritated tongue and the broken areas at the corner of the mouth, that chelosis, and then diarrhea, and definitely GI. There are not neurologic symptoms, though, with folic acid deficiency, and they're not with the iron either. So if you think the iron helps build our hemoglobin, the B12 helps with our nervous system, peripheral and central nervous system, and then the folic acid in the B12 work together with the DNA production. But what about folic acid, Isabel? What does that lack of it do in pregnancy or birth or whatever?
Honestly, I haven't seen any problems with that. Most people that I've seen have had good vitamin intakes with their like the prenatals, yeah. So I haven't really seen what happens.
Yeah, and the thing about it is the spinal column and all it's formed really before some people even know they're pregnant. Thank goodness that you can get the pregnancy test and find out early. But if you haven't skipped a period, that development's already going on. And does anybody know what folic acid deficiency does if somebody's pregnant and they don't know it, or they were deficient before they got pregnant? Yeah, like spina bifida. Yeah, the neural tube defects is what they call that. But spina bifida is the most common one, where it's not, the spinal cord is not protected by, it can be just on the outside even in some cases. So it's meningomyelocele spina bifida. So neural tube defects. So that's the thing that's sort of a unique thing to remember about the folic acid deficiency. And the supplements can be used for the deficiency along with the diet. All right, and here's our folic acid, the green leafy vegetables. See, we got that with iron in our B12 and all too. And the fortified fruits and cereals and meats and liver and meats and dried beans and nuts. Most of those are very similar. Okay. Okay. This is hemolytic. That's when hemolysis, it bursts the cell. What's inside of a cell as far as the main electrolyte inside of a cell? Potassium. Did y'all learn that in fluid and electrolytes? Potassium. Yeah. So if those cells are busting up all over the place, what's going to come out?
Hyperkalemia.
Potassium, and it's going to be, you're going to see that in the bloodstream, aren't you? You can have high potassium in the bloodstream, and the kidneys try to get it all out and everything, but with a hemolytic anemia, you can have a high potassium. And another issue sometimes is maybe what's floating in their bloodstream is not, the potassium that's floating in their bloodstream is not, that's not well. Let's say I'm doing it backwards. Okay, you've got the red blood cells that when you actually do a blood test, when you pull the blood out, and it's really hard to get out. Sometimes you have to pull it out with a syringe. Some of y'all are phlebotomists, and you've done this before. Have you ever had to do it with a butterfly and a syringe? And it's really hard to get it out, or if it's really hard to, if it's tough to come through, and you have to kind of adjust the needle and all this kind of thing, that trauma can burst the blood cells, and then you can have like a falsely high potassium count because those busted cells just putting them into the tube, and you have to go through trauma to get trauma to the cells when you're taking them out. It's not going to be, it'll be like a false elevation. So if you see somebody with a hyperkalemia just once and then they've not been treated for it or anything, sometimes they actually will just take another one to make sure that there wasn't hemolyzed cells. And sometimes looking at it under the microscope, they can tell that it's been hemolyzed. So, what's that?
If the serum is red,
so you know it's busted then, or it's hemolyzed.
and we usually, if the potassium is high, we usually put in there hemolyzed, if it's moderate,
Oh, good. So it's a lot easier to tell now then. Okay. And then you can have problems with if you have abnormal red blood cells that are released from the bone marrow. It can have defects in the cell membrane and defects in the hemoglobin structure and function sometimes, and enzyme deficiencies can cause that because of the red blood cells themselves. Then the outside of the RBC, some medications can cause the hemolytic anemia, and bacteria and other kinds of poisons that can go into your system, and then trauma, especially to the red blood cells. And we can stop here now because I just thalassemia and stuff is just something I don't want you to at least have heard of. We'll talk about that tomorrow. We started at 9 o'clock. 9 to 12 or 9 to 12 minutes.